button, guys. Give me 1 second. Awesome. So thanks everyone for coming to our February regional rounds. Before we begin, I just want to remind everyone that the survey will be up for you to give feedback on this talk, which would be much appreciated for our speaker. Additionally, the link for the CPD website is up there, which has also the YouTube link as well. And people for watching on the YouTube link, check out our other regional rounds from the past. All of them should be uploaded on our YouTube site. And so last but not least, if you have questions, feel free to add it on the chat box here, and I could interrupt Carys hopefully at good junctions to ask those questions. And then at the end of the talk, I'm assuming Carys will have some time for questions for open questions for her talk. Otherwise, I'll just introduce everyone to this amazing speaker, Dr. Carys Massarella. She's an assistant clinical professor in the Division of Emergency Medicine, Department of Medicine at McMaster University. She is the lead physician for the Transgender Health Program at Quest Community Health Center and an attending emergency physician at St. Joe's Healthcare in Hamilton. She speaks widely on transgender issues and is a leader in transgender healthcare in Canada. This is amazing. She was recently named by the Maclean's magazine as one of 50 Canadians who are breaking ground, leading debate, and shaping how we think and live. She has appeared in numerous documentaries, recently starred in the Amazon Prime Out TV series My Trans Journey. She has also done 2 TEDx talks on transgender-related issues. Her goal is to provide high-quality, gender-affirming healthcare for all Canadians, regardless of where they live. Additionally, she also recently did a MacEmerg talk with us. So if you want to check that out as well, check out the CPD website. Otherwise, I'm done talking. Carys, you have the floor.
Hey, Kevin, I just have the meeting is being recorded icon in front of me, and I can't seem to get rid of it. So if you could, I don't know how to get rid of it. It's frozen there.
Oh, weird.
Yeah, I can't. I'm completely frozen.
Perfect.
Yep.
Okay.
Perfect. Yeah,
go ahead.
I'm good. Okay. So thank you everyone for coming today. As you know, most of you know me, so I can dispense with all that type of introduction. But essentially today, we're going to really touch on what's going on in Ontario in transgender healthcare and in a broader sense across the country in 2021. So just the objections again to understand the state of transgender healthcare in Ontario in 2021, just some basics around transgender healthcare. So when patients come to the emergency department, you have some understanding of what we're doing in the, in the office or in our clinics. And then probably the single most important thing that we can do, and actually is the one issue that when you talk to transgender patients or review their experiences in an emergency department, is just more the improving the actual ER experience. It's not the healthcare we provide, it's the experience that we provide. And then just again, with relation to emergency medicine is some of the complications related to transgender healthcare that you might see, we might see in our departments. And just I have no conflicts to declare. And so the first thing again, I think is just doing a quick review of transgender terms. Now I know a lot of the younger doctors are pretty aware of this. But terms change all the time. And even with my time doing transgender healthcare, the terms have changed significantly. So the still umbrella term is transgender, which in its most simple definition is just somebody whose gender identity or expression is not the same as the gender they were assigned at birth. A term that is less common than it used to be, which has sort of been replaced by non-binary, is the term genderqueer, where people don't necessarily identify with male or female or part of the gender binary, but may have a different type of gender experience. Cisgender, which are people whose gender identity matches the gender they were assigned at birth, or as people in the transgender community like to refer to cisgender people, the less gender gifted. Again, not your fault. Blame your parents, blame somebody else, but it's not your fault. And then of course we have non-binary people, which is an interesting sort of, I hate to use the term phenomenon, but it's an interesting sort of identity that we've been seeing with increasing frequently over the years. When I first started doing transgender health back in 2010, we saw virtually very few or no patients who identified non-binary, but in the last 5 or 6 years, the number of non-binary patients that I've seen has grown significantly in my practice. I would say about up to 20% of the patients we see now identify as non-binary. And again, a lot of younger people are identifying as non-binary. The interesting part about non-binary identities, though, so the vast majority of people who do identify as non-binary, somewhere north of 90%, are people who are assigned female at birth. So we don't see it a lot in people who are assigned male at birth. I think there are social cultural reasons for that, but that's sort of the majority of people we see who identify as non-binary. Then the other term that you can use, and these are terms that you can use in your chart, I believe, and they're respectful, and I think they're appropriate to use in the chart. The other one is transgender male or trans male, and that's somebody who is transitioning from female to male. And the other one is trans female, which is somebody who's transitioning from male to female. And the other even newer term that I've heard recently is a lot of people identify as either trans feminine or trans masculine, meaning, again, they may be in the non-binary spectrum, but they may be more feminine in their presentation, or they may be more masculine in their presentation. So we certainly see different terms. And as I say, even for myself, I have to talk to the young people to keep up. So again, when people talk about, trans populations, what numbers are we referring to? And I think it's always worthwhile looking at that number. And one of the things we should remember, and particularly for those of you that are researchers, when you're trying to measure marginalized populations, it can actually be quite difficult to actually identify people who are marginalized, because they may not identify with that group for lots of different reasons. And so, for example, somebody may not identify as transgender because they're not out or gay or what have you. It's a little bit different with racialized people, because unfortunately, racialized people don't have a choice as to being out or not. But certainly amongst queer populations and LGBTQ populations, it may be difficult to identify accurately those populations. And so one of the ways in research that you can do is something called respondent-driven surveys, where actual members of the community then pass it on to another member of the community, because often people in that community know who the other members are. And just to remember, transgender does not equal transition. So somebody may identify as transgender, but they may never choose to undertake a transition, either social, surgical, or hormonal. And I think the other thing that we should always remember, that being transgender is an identity, it's not a pathology. One of the harms, a lot of the mistrust that occurs from the transgender population towards the medical community, and trust me, there is a lot. I just heard about it from one patient this morning I saw in clinic, or spoke to in clinic, is that people over the years, before the DSM-5, which came out in 2013, transgender identity was identified as gender identity disorder. And so when you sort of think of something as disordered, then you think of something that may have a cure, and cure meaning you're no longer transgender. Well, I always pose the question to cisgender audiences or queer audiences, is how many people, listening today think that their gender is an illness? And it's really the same for trans people. Being transgender is not an illness. Things that happen to you, being marginalized, losing your job, being homeless, being afflicted by violence, either emotional, physical, or sexual, those things might affect your health. But if you identify as transgender, your heart doesn't fail, your kidneys don't fail, your lungs don't fail. So it's really important to keep that in mind, and to remember that gender identity, gender expression is not an illness. So just to try and look around the world, and again, mostly around the world, we're talking about the Western world, which is really the only place, or OECD countries, that really measure transgender populations to any significant extent. And just one other group I'll mention really quickly is intersex people. Another group that was sort of traditionally quite harmed by the medical community, meaning that they often had surgery performed on them without their consent at birth. And as the old saying goes, with surgeons back in the early 70s, late 60s, was it's easier to make a vagina than a penis. So a lot of people whose gender identity didn't match their gender, their genitals, were basically given female genitalia in a sense, and that didn't match who they were, and that often caused harm to those people as they got older. But when we look at prevalence, around the world, what we're looking at is a pretty consistent number. And Canada, I think Canada's numbers is not adequately measured for a number of reasons, but it really varies from about 0.5 to 1% if you look at sort of around the world, or at least where we measured in the Western world, I should say. And I think I would like to put that into numbers just so we can think about it in terms of where we live. So if you look at, say, for example, Hamilton, right? We've got about 550, 600,000 people now in the Hamilton region. If you take 1% of that population, that's about 5,000 to 6,000 patients, 5,500 to 6,000 patients. And even if you use the lower number, that's still 2,500 to 3,000 patients who would identify as transgender, or essentially 2 to 3 full-time family practices just for transgender people in the Hamilton region alone. So that's something that we need to think about when we think about actual numbers. I like to do it that way because it gives us an idea of how many people we might be dealing with. And then this is just Canadian surveys, when we look at people who experience, sexual violence, other forms of violence, who identify as transgender, and as you can see, transgender people in all categories experience an increased, violence, unwanted sexual behavior, took protective measures to avoid harassment online. And you can see that transgender numbers are significantly higher than those in the cisgender population. And, harassment online is a real issue. One of the reasons I don't go on Twitter is because I don't need that. I don't need that in my life, to be quite honest with you. But those, again, remember, these are Canadian numbers. They're not United States numbers. We always like to think that our cousins in the United States are less tolerant, but in Canada we also don't do as well as you would hope. But what is more interesting, in the United States, it is actually perfectly legal to discriminate against somebody who is LGBTQ in terms of healthcare, in terms of housing, in terms of access to public services. That is actually legal in 29 states, in the United States. So again, when we look at general populations, a lot of these statistics, if you actually look at other marginalized populations such as homeless people, people with addiction, Indigenous people, a lot of them have similar numbers. And again, I think it speaks to the social determinants of health, not anything that speaks to pathologic nature of being one of those groups. And so when we look at trans Canadians, again, these are trans pulse, these are Canadian numbers. 43% identified as having had a history of mental illness versus about 20% in the general population. 33% considered suicide and about 5% attempted suicide. I think, but what's more interesting is if you provide gender affirming healthcare to people, particularly to transgender youth, those numbers decrease to their age match controls. So we know that gender affirming care and access to healthcare reduces those numbers to approximately the same as the general population. About 15% often report not having enough to eat. Yet at the same time, again, transgender people are better educated than the general population as a whole. And so again, what that speaks to is more of institutional discrimination, as just by numbers alone, we should see transgender people doing it as well as their age match controls. And again, in terms of abuse, up to 68% verbal, 16% physical, and 42% sexual harassment. So for example, one of my transgender women was walking along the streets in Hamilton. I heard this story recently, and a car driven by a group of young men drove past a person. They then stopped, turned around, came back, and threw a bag of feces at that patient. So, it's real, it exists. It's often not reported to the police. And the reason often, again, transgender people don't report it to the police is because they don't have faith that the police will treat them fairly or take their issues seriously. And that, again, does happen in Hamilton. Again, as I talked about the non-binary, sort of the increase in non-binary people presenting to our practices. So you can see, again, when we look at the distribution, it is a lot younger people who are presenting as non-binary. Most older patients, so over the age of 35, 40, are still presenting as, in a binary way as trans male or trans female. But a lot of our younger patients who are presenting to our clinic are presenting as non-binary. And again, just remembering that non-binary people may still want to have some type of hormone care or surgical care. So it doesn't exclude them from having any treatment. And again, just looking at education, again, we can see that close to about just over 70% of transgender Canadian non-binary Canadians have a higher level of education. So again, the numbers are skewed despite higher levels of education. Transgender populations, non-binary populations experience increased homelessness, they experience increased poverty, they experience food insecurity and housing insecurity at a higher rate than their age match peers. So coming to what sort of I look at and what I see quite frequently is what I would refer to as unmet healthcare needs. And so 45% of transgender Canadians reported one or more unmet healthcare needs over the past year, although 81% reported having a primary care provider. And again, 12% reported avoiding going to ER because they thought they would be treated negatively. So we should think about one in 9 people will not come to the emergency department because they feel they get treated poorly. And that's not always by emergency staff, to be clear. It's sometimes it can be in DI. It actually, quite frankly, often in DI. Sometimes it can be from consulting services. Sometimes it can be from even people delivering food and things like that. I mean, we have to remember that the department is a large organic, being, and there are many different parts in that being. So there's housekeeping, there's nutritional services, there's RT, there's PT, there's OT. There are the emergency physicians and emergency nurses, consulting services. And so it really only takes one person in that pantheon of people to do something, and that can create a negative experience, resulting in that person not coming or not having a healthcare need met. So again, I think it speaks to the point that we talk about when we look at a hospital, we can't look at it as a single isolated space. We have to look at it as a whole structure, because everybody interacts with the emergency department. So looking at our legal obligations in a sense for transgender people is that in Ontario, so I should start out by saying every province and territory in Canada has gender identity, gender expression protected as a human right. And federally, gender identity and gender expression is protected as a human right. And so what does that mean? Well, what that meant for transgender people, and you think, oh, what's obviously we treat people well, which is not true, as I've demonstrated, but what does that mean? It means you have access to surgery without having to see a psychiatrist before you can access surgery. It means that you have access to housing. It means you have access to all sorts of things that you might not have access to if this form of discrimination was not allowed or was allowed. Other one I just want to touch on is something called Bill 77. And what that does, it outlaws something called reparative therapy in Ontario residents for anyone under the age of 18. And what that is, sort of like pray away the gay, in a sense. So if somebody wants to comes to you and says, I want you to cure my child, make them not trans, or make my young adult not trans, you can say to them, well, first of all, if they're under 18, it's illegal, sorry. But even if they're over 18, every major regulated, credible profession in Canada is opposed, and it's unethical to practice reparative therapy. Well, just to be clear, so just to let you know, the college, whatever, the Royal College, the College of Family Physicians, each and every organization would consider it a breach of your professional obligation if you engage in reparative therapy. Just again, to touch on medications that you might see people come into in the emergency department. Obviously, when we talk about transgender women, we're talking about two medications that we normally use. One is estrogen, and for the most part, we use what's called 17-beta estradiol. It's really given in 3 different forms for the most part. The most common form is estrace, which is an oral medication. The obvious reason we give that is because, quite frankly, it's the cheapest. And it's also the one that's covered by the ODB, and for people who are on ODB or benefits for ODSP. The second one is the Estradot patch. I like the Estradot patch. It's what I personally used for many, many years because you can use lower doses and you bypass liver metabolism. So that's one of the reasons that we like to use the Estradot, or I like to use the Estradot patch. Unfortunately, it's not covered, but it will be covered by private drug plans, and it can be relatively expensive, about $170 every 3 months. With that patch, often people will sometimes complain about falling off in the shower with exercise, or sometimes they get a rash around it. That's usually the biggest complaint. Third one is injectable estrogen. You'll find a lot of people might ask you about that because on the internet, there's a lot of anecdotal evidence that if you take injectable estrogen, you get better or quicker results. And just to be clear, there is no evidence that occurs. And then finally, there's estrogel, which I've never had a patient use it. Usually because you have to use such a large dose, and it's a real pain in the butt trying to rub that gel into your skin over a prolonged period of time. The other medications that we use are anti-androgens, and there's 3 main anti-androgens that we use. One is Lupron, which is an injectable GnRH agonist. The other is spironolactone, which is a drug that you're familiar with, which we use in cirrhosis and heart failure. But interestingly enough, when we're using it in elderly people, we're very careful to use like doses of 25 milligrams, maybe 50, because, they all get elevated potassium and creatinine all goes up. But if you're a healthy young person and you have normal kidney function, which I did learn just by trial and error, is that you can flog those kidneys with spironolactone. Like I have some of my patients on as high as 300 milligrams of spironolactone a day, and there is no effect on their creatinine or their potassium. The only thing a lot of them don't like is a diuretic effect. So that is a drug that I used to use almost exclusively, but now I have mostly switched to another drug, which is called Angicur or Ceproderone. And that's a drug that it has a bit of an interesting history because it was used for chemical castration of sex offenders. But again, the whole goal of using an anti-androgen is to block testosterone. And so you get the maximal effect for feminization for for trans women if you use both estrogen and an anti-androgen. For transgender males, we use we use exclusively testosterone. There are two main types. One is called depo-testosterone, the other is called deletestrol. There has been some shortages of those, for the mysterious reasons that we have shortages of all drugs in our system. But so sometimes you have to switch between the two just because there's some unexplainable or inexplicable shortage. Or maybe there's just a lot of 50-year-old men who need their tea as well. Anyways, it's usually an injection that we use once a week. Usually complications associated with injection, just hematoma, sometimes sterile abscess, sometimes infection. It doesn't happen very often. Most of our clients do their own injections. We generally will teach them, at our clinic how to do their own injections. Well, I don't teach them, obviously the nurses do, because we want them to do it properly. But also, it's funny, I've had one client, and I'll say his name is P, and he has actually, I first saw him like almost 10 years ago in the clinic, and he has come literally every Tuesday for 10 years to get his injection. So commitment. And then again, and of course, the injectable testosterone is the one that's covered by ODB, ODSP, and seniors benefits. The other one that we use most commonly is androgel. I tend to use that in people who are needle phobic, which I do have the occasional patient who is quite needle phobic. Again, it's not covered, and even if you try and do a EAP or exceptional access request, they won't approve it. But androgel is covered by all private drug plans, so again, if they're fortunate to have a private drug plan, then it will be covered. And a very, very small number of patients use the androgen patch. Most people don't like it because it's really quite big. And like, it's not like the estrogen patch is literally the size of a small Band-Aid, like maybe that big, whereas the testosterone patch is like that big. And no, I wasn't doing a just, but I'll give you a heart anyways, because I love you all. Oh, and there's my talk about some of the anti-androgens. Some other ones you might see people use is finasteride or dutasteride. I tend to use those in for hair loss. It's because they block what are called D1, D2 receptors, which are located on your hair follicles, and are quite effective from that perspective. The other one you see sometimes is Superfact, which has a similar effect to Lupron, and then bicalutamide, which is a drug that's used. I never use it for the simple reason that it can cause pulmonary fibrosis, and I don't think there's ever a reason to cause pulmonary fibrosis in a transgender person from a drug side effect when they have so many other choices. And so that's sort of the medications that we use, sort of a short, well, really a pretty exhaustive list. I don't think you'll see other medications being used specifically. And so it's worthwhile familiarizing yourself with those medications. But again, they're all really medications, probably short of Androcur and Lupron to some extent, that we're relatively familiar with. The only other thing I would talk about, and this is why it's really good to take a sexual history and be comfortable taking a sexual history, and I do talk about the residents with this. It is really important to be able to take a sexual history because there are a couple of things that we can do in the emergency department that can be really important. So especially if you have a transgender male who is engaging in penile vaginal intercourse, it's a good opportunity to remind them about the teratogenic effect of testosterone. And we generally recommend an IUD like a Mirena for anybody who is going to have penile vaginal intercourse if they're on testosterone. I have had a couple of patients who have gotten pregnant over the years on testosterone, and we have referred them for therapeutic abortion. And the other thing to remember is if people are in a high risk group, especially MSN, so people who might be engaging in high risk behavior for HIV, we can think about PrEP. And PrEP is something that's worth, as emergency physicians, becoming familiar with. That's pre-exposure prophylaxis for HIV, which is essentially a single dose of I can't remember the name of the medication right now. It'll come to me, but it's a single dose of an HIV medication. And if you give it to people who are at high risk with regards to sexual behavior and to take it every day, then you can actually reduce the risk of HIV transmission by about 99%. And even if they're an IV drug user, it's about 70%. So there are opportunities in the emergency department to intervene and do actual interventions that are meaningful. So really there are sort of three parts to being a transgender person. One is a medical transition, which is a lot of what I do, which is where we see somebody and we provide hormone treatment. And the objective of medical transition is to provide that individual with the secondary sexual characteristics of the gender they identify with. Just to give you an idea, we are receiving about 500 new requests for referral every year. And the youngest patient I've seen is 3, and the oldest patient I've seen is 82. And actually today I had a lovely chat with a 6-year-old who I've seen before, who I'm following along, who's quite a character. So, it's really actually really rewarding work, I have to be honest with you. And we actually do have a larger pediatric and adolescent practice than I ever suspected I would. I do refer anybody under the age of 14 to McMaster for medical treatment if required. Um, and that's the McMaster Clinic. So if they're under the age of 14 or anybody under the age of 18 in Hamilton who comes to your department, you can refer them to Natasha Johnson's clinic at McMaster, and that's Natasha Johnson and John Vandermeulen, who's a pediatric endocrinologist, who do that. The only problem is the wait list is crazy. It's like, I think, 2 years right now. But again, if we look at pediatric and adolescent trends, we have seen about a 10 to 15-fold increase, and this is again unique across the world. Again, I should give that caveat, the Western world, of presentations to pediatric gender adolescent clinics. So about a 15 times fold increase in the last 10 to 15 years. We use what's called the informed consent model, which is really the standard model of care for most adult transgender patients. However, we should remember, this is a really important point that probably most of us are aware, there's no age of consent for medical or surgical treatment in the province of Ontario. It's actually all about the ability to understand and be responsible for your own healthcare. So technically, a 12-year-old can consent to treatment. And we should always remember the case of Michaela Soul, who was a young Indigenous female who had acute lymphoblastic leukemia. And Mac sort of went the traditional route where they were going to, take control and give her treatment. But the judge actually ruled that she was competent to make her own decision, and she actually declined treatment. The sad part is they went to a clinic in Florida, which I don't think was really a proper clinic, and she did tragically end up dying. But regardless, we should remember that about consent. Again, I don't require a mental health assessment, except that there's a mitigating factor, like they're actively psychotic. Again, there's no person that wouldn't benefit from psychotherapy if they have gender dysphoria. Everybody, I think all of us would benefit from psychotherapy, but definitely there's anybody who's experienced gender dysphoria, psychotherapy is helpful. I certainly did psychotherapy, but again, the issue around psychotherapy is mostly cost and people's ability to afford it. Again, we use cross-gender hormone therapy. We do refer our patients for surgery and provide post-op surgical care. And again, just to remind you, around age of consent. Surgery in Ontario, as of 2016, you are no longer required to see a psychiatrist prior to being approved for surgery. That was interesting because, again, can you imagine, you're an otherwise competent adult who knows exactly who you are and what you want, but you have to go speak to a psychiatrist first before they will approve gender surgery. And the only caveat being, if you could afford to pay for it privately, you could just skip all that nonsense. But it was really, I think, quite wrong. I mean, it'd be like, if you had your, 85-year-old grandmother who needed hip surgery or hip replacement, and you said, well, you know what, grandma, it's great. We're gonna get you hip surgery, but first, just to let you know, you got to go speak to a psychiatrist first to make sure you're not delusional about your hip pain. And I think it just speaks again to creating a sort of special class of people that transgender people are constantly put into, where they're told that they're not just not like normal people. They have all these special rules in order to access treatment. Yes, I think with pediatric populations, it's a bit different, and we do manage our pediatric patients very differently. But I think for a competent adult, and thank goodness that's no longer the case, that we should be able to they should be able to understand who they are and what they're doing. So now anybody can refer somebody for surgery. So it can be an MD, NP, RN, registered social worker, registered psychologist. However, for any type of bottom surgery, so vaginoplasty or phalloplasty, you do have to have 2 signatures, and one has to be an MD. And who can do it? Basically, if you actually read the Ontario guidelines, that anybody who feels comfortable managing gender dysphoria. The only problem we run into is, the only place that really does significant number of bottom surgeries in Canada is a private clinic in Montreal called GRS Montreal. So no public hospital does them, except now Women's College program is finally starting up, and they're also starting one in Vancouver. But everybody else goes to Montreal to a private clinic, and the group there, who've done amazing work over the years, still use a WPATH guidelines, which still mandates that you have a psychiatric assessment prior to surgery, but we have a workaround because they know us well. So we don't require it at our clinic, but for some people, they still demand it. So again, just to review, gender affirming surgeries are covered in Ontario. And those include such surgeries as vaginoplasty, which is where you create a vagina for a transgender female. It takes only about an hour and a half to 2 hours. It's a relatively straightforward surgery, believe it or not. It's basically you do what's called penile inversion surgery with bilateral orchidectomy. You use the head of the glans penis, right, which is anatomically is the same structure as the clitoris to create a clitoris, and then you use the scrotum to create and the skin of the penis to create a vagina. And usually the biggest common side effect we see that is vaginal stenosis related to dilation or not using that because it's not a naturally muscular structure, and will stenose down if people don't actively dilate if they're not engaging in penile vaginal intercourse. Phalloplasty, which is usually done in 2 or 3 stages. That is a very complex procedure. It has a complication rate of probably around 100%, meaning that everybody who has a phalloplasty usually has some form of complication, usually related to urethral stenosis. It's interesting, if you get that surgery done out of country, the actual cost is about $150,000 US, just to give you an idea of the cost. Vaginoplasty, if you have it done out of country, you pay for it privately in Canada, is about 20,000 Canadian. Again, other surgeries that we do are orchidectomy, which is removal of testicles. That doesn't preclude having vaginoplasty as long as it's a midline orchidectomy. That's done locally. There's a surgeon in Toronto, Dr. Vlahovic, at Toronto East General, who does that surgery. Another surgery called metoidioplasty, which is a sort of a kind of like a phalloplasty, but much simpler and more straightforward. Basically, with metoidioplasty, you dissect out the fibrous ring of the clitoris and lengthen it. And then you create an artificial scrotum from the labia and create masculine appearing genitals, but they're not functional in that sense, and usually not enough to be standing up, which often is the goal of my trans male clients. Sorry, humor. But actually it really is a goal for some of them. And breast augmentation is generally not covered. If somebody has like 0 breast growth on hormone therapy, we can apply for breast augmentation surgery, and sometimes it gets approved. And then there are other surgeries that are not covered, like facial feminization surgery, facial masculinization surgery, things like electrolysis, voice therapy. So something like electrolysis, if they have a heavy beard, can be upwards of $30,000. FFS, can be, which I actually had, usually runs somewhere between $75,000 to $100,000. Voice therapy is usually $60 to $120 an hour. So again, this is quite expensive. A lot of this stuff. Again, there's only one surgical site that's doing consistently bottom surgeries, which is the private clinic in Montreal. And again, my perspective on cross-gender hormone therapy is that really all of us could do. I mean, yes, I'm an emergency physician. My colleague, Dr. Saint-Amand from St. Catharines, some of you may know, an emergency physician. We both work together at our clinic. He came on, joined me about 5 years ago, which has been wonderful. And our nurse practitioner, Nazila, there's 3 of us who do most of the care. But we do it. Now, I know as emerge docs, our theory is, yeah, we could do it. I think I was just joking about that last night with John Sherbino. We've been talking about Keppra. I figured, yeah, it sounds like a reasonable dose. Let's try it. So, I mean, I think as emerge physicians, we have a slightly different attitude than a lot of other physician groups. But I can tell you with certainty that I do far more complex things in the emergency department with regards to pharmacotherapy than I do with regards to cross-gender hormone therapy. It really is not that difficult to do. It's definitely within the scope of primary care, which I preach constantly. However, it is often better to do it in a multidisciplinary model, I think, is the way to go if you can. But not everybody can do it that way, but I think it's still the better model. So again, next frontier is improving surgeries and options for surgery, younger patients being seen and earlier treatment being initiated, and more physicians interested and involved in transgender care. In the last 10 years, I've certainly mentored a lot of physicians who are now doing trans care in Hamilton. So there's a number of doctors who are doing, Dr. Ellen Clark at Stone Church, Dr. Kevin Valakari in his practice, Dr. Rob Kerr, who many of you know, certainly if you worked at the HHS, who was an emergency physician who's doing family medicine now, are all Dr. Siobhan Callahan. So these are all docs who do trans care. So it's getting better. It's still not where I'd like to see it, but we're definitely getting better. And so that's still a goal, is to make sure. And one of the reasons I use that as a goal is because when you survey trans populations, what's their number one ask is to have access to gender affirming transgender care. And that still does not happen, particularly in rural environments in the province of Ontario. So one of the terms I just wanted to talk to you a little bit about just is the experience of transgender women in our society. This is a very loaded and controversial term, which sort of speaks to whether or not a trans woman looks like, quote unquote, a woman. And we all know that women come in all sorts of different shapes and sizes. And interestingly enough, when North Carolina passed its bathroom ban, a lot of very masculine women were being actually held up at bathrooms and accused of being a man in a bathroom, so in a woman's bathroom. So, there are lots of unintended consequences. Thank God the governor who passed that law was replaced by a Democratic governor by the name of Roy Cooper, and it has gone away as an issue in North Carolina. And I often like to say too, something I always talk about is that wherever they've had, gender non-discrimination laws in communities, United States or Canada, there are very vanishingly small, if not any, cases of transgender women assaulting other women in the bathroom. Because really, as far as I'm aware, there's no security on bathrooms, and a man can still walk into any woman's bathroom and assault a woman or girl in a bathroom. But what we do know, and I have pointed this out once in front of our bishop, is that lots of Republicans, far more than transgender women, and lots of the clergy have been accused of assaulting people in bathrooms, more so than transgender women. So I always pose the question: who should we really be banning from bathrooms? Well, the answer is no one. We don't punish entire groups. We punish behavior. But an ability to pass is often judged as a successful transition. And I think it's very challenging because, again, when I talk about some of the costs, like somebody like myself who's privileged can afford to do a lot of those things that other people can't afford to do. So, I'm lucky I get to pass as a middle-aged woman in Oakville, blonde woman in Oakville, which is, I like to think of a hell of a life achievement. But nonetheless, it's fortunate because it means when I go outside in my daily life, I don't get bothered, I don't get harassed. But for many of my patients, and I just salute their bravery, they walk out there every day, and every day they get misgendered. Every day they get yelled at. Every day they experience emotional abuse. I think it's horrifying. It shouldn't be necessary, but it is a fact. And so one of the interesting advantages of transitioning somebody at a young age is that, my young transgender women who I've followed since they were 8, 9 years old, who transitioned at puberty, you would never, if you met them, you would have no idea that they were ever assigned male at birth. It's a really, it is an amazing thing, especially for those young women. As I said, trans misogyny is alive and well, and I sort of discussed this intro, but it's really interesting. Like, nobody seems to care if trans males go use male bathrooms, but people really seem to care if transgender women use female bathrooms. Not in this group, obviously, not so much in Canada, but it's interesting too, because, as I like to tell people, you've been using the bathroom with transgender women for years. You just didn't know. It's, again, directed at that group of unfortunate transgender women who would be called non-passing. And I've actually, believe it or not, testified in 2 human rights commissions around bathroom issues, at the Human Rights Commission twice in the last decade regarding that issue. And again, the other one I often hear is like, well, you hear from certain groups of people, well, you were assigned, your biologic destiny is your male or female, your chromosomes are XXXY. We already know that intersex people exist, so we already know that that's a fact. And secondly, we as physicians interfere in biologic destiny all the time. I mean, it's something that we do on a regular basis. I always make the argument, if your child has leukemia, well, if that's God's will, why do you treat it, right? I mean, and there are some groups that do that, or they try and pray it away. But I mean, the point is that, of course, as physicians, we intervene. Of course, if we have ways of making people feel better, do better, then we intervene. So I think, from my perspective, to argue that, your chromosomes are your destiny, I think is absurd, because nature doesn't do that, and nor should we. So just going to talk a little bit now before I finish up and give some time for questions. I just want to talk a little bit more specifically about the emergency department. And so some of this is US data, because we don't have this data in Canada, sorry. But, what are some of the reasons that people don't use the emergency department? Well, the first one we don't worry about in Canada because of, medical insurance isn't a huge issue here. But fear of being outed, misgendered, or experiencing discrimination. I hear this from my patients all the time. And again, I wanted to point out it's not often the emergency personnel themselves, right? Because I think emergency departments are getting much better at it, particularly in Hamilton, which may reflect myself being here in Hamilton, or it may reflect just, I think, our society changing in general. But as I said, it's a whole hospital experience. So it doesn't matter if we're good. Doesn't matter if the triage nurse is good. Doesn't matter if the emergency nurse is good. doesn't matter if our OTs and PTs in our department or RTs in our department are good, if it's a consulting service. But often the place I do find is DI. And so if you do have a moment to point that out, especially if there's somebody that's relevant to that complaint, yes, I tell my transplants, if it's relative if your presentation is relative, being transgender is relative, like a genital abdominal complaint, then you should disclose that. But us as providers, we can at least, call radiology or let them know that we have a trans patient coming down, and just, be sensitive, be kind. And for the most part, that works. It really does. And that's usually all people are looking for. They're not looking for a miracle. They're looking just, I think, for some empathy, kindness, and maybe using it, not dead naming them, and maybe not misgendering them. Provider behavior. I definitely used to see this years ago before I actually transitioned. Now, I don't see it in my department, certainly not when I'm working. Whether or not it occurs when I'm not working, I don't know. I haven't heard of it. I mean, I really don't think it does occur at the same rate that it used to. But, one thing, and people hear, right? I mean, we often forget that people hear what we're saying in the emergency department. And I'm just as guilty. I am not a paragon of virtue here. But we do have to be careful sometimes about what we say, because patients do hear. Patient-provider encounter. So, past experience of being purposely outed by a healthcare professional. Absolutely. I just had a patient today, ironically, I spoke to this morning, who at their pharmacy hasn't changed their name legally, but has a preferred name, clearly presents as female, where the pharmacist in a loud voice said to them, "Oh, Mr. Blank Blank, sir, your prescription for is ready," which was for estrogen. You think that might prevent somebody from going to this pharmacist? Do you think that might happen? And the answer is yeah. Or when I know that I send somebody to a consultant, like I send them, for urologic follow-up, psychiatric, whatever I'm referring them to. And I get a letter back, and I know, again, they're transgender female and they're presenting as female, or transgender male, I know they're presenting as male. And I get about, this gentleman presents to me his using their dead name, using male pronouns. And you think it's not a big deal, but those people don't go back. They don't go back for follow-up. They don't get the right healthcare. So it's important. Again, it's getting a lot better, like fantastically better in the last, 5 to 10 years, but I still see it over and over again. And I have heard of it being on our eMERG records as well. Several of family doctors, Rob Kerr actually, sent me an email about that, saying that he's seeing that happen on the electronic medical record frequently. So again, please use preferred name and pronouns even when you're dictating on your record. Again, past experience of staff refusal to use preferred pronouns, and past experience of transphobia as a patient. And so one of the things I guess we should also remember is when somebody comes to the emergency department, unless the complaint is relative to their transgender experience, they don't need to ask them about that specifically. Because I always say, as far as I'm aware, the transgender strep throat is exactly the same as the cisgender strep throat. The transgender shoulder dislocation is the exact same as the cisgender shoulder dislocation. So again, think about it, try and do your best, be sensitive. Systems issues, again, on your EMR, not being able to use a preferred name, preferred pronoun, gender identity. How do you cohort your patients specifically with regards to gender and identity? And then providers are poorly educated in TGN, GN, so transgender, gender nonconforming, health-related issues. So again, I think things that we need to think about. But again, I think the one that, if you look at the one that's the highest, is the past experience of staff refusal to use preferred pronouns. I mean, again, like, that's just being kind and being empathetic. It doesn't cost you anything. It costs you nothing as a provider to do that. But it costs that patient a lot. And again, we published the first article on that in 2015 in the Annals of Emergency Medicine. And again, this was in Ontario, that 33% of people would avoid using the emergency department if they had a perceived emergency. It may not have been an emergency, but it was an emergency to them. Would avoid because of these issues that they experienced in the emergency department. So this is real world health effects. And I've seen lots of my patients who don't go back for follow-up because of the way they get treated in that environment. And again, for every concern, we need to have an answer, right? And so again, what do we do about ourselves as providers? Do not discuss gender identity or that experience with others, including healthcare providers, unless it's relative to the provision of care. Ask sensitive questions in private spaces. Again, don't go, into a large waiting room. I know we're all pressed for space in our emergency departments. It is a challenge, But again, when you're talking about things like that, try and do it privately. And again, try and avoid using prefixes or first names if you're not 100% sure. But hopefully that's been identified at triage or through demographics that that patient is using a preferred name, preferred pronouns. And again, what I do, I ask everybody, I mean, I get some weird looks, but I ask them their preferred name and preferred pronouns. If they have a preferred, if they have a birthday on a chart or they have preferred pronouns, I do ask that. Once you get used to it, it's really not that big a deal. Some people think you're weird for saying it, but I'm weird for lots of reasons. So it really doesn't bother me. Again, do not ask about gender and or TGGNC experience if it's not relevant to ED care. Avoid gender specific terms, including social titles. And then systemic, and again, when you talk about systems issues, and I've argued this, that we need training around gender affirming issues, gender surgeries, gender treatment, about social stigma and marginalization of populations and in marginalized populations in general. I mean, AOAR, anti-oppression, anti-racism training is useful. I did it about a month ago with the board of the YWCA as a member of that board, and that was really good. I mean, I always feel I'm pretty up to date, but you always learn something new, and especially hearing personal experiences is always very powerful, and always affects the way that I think about these issues. Trying again, we do in our EMR at St. Joseph, people bother to put it in, incorporate pronoun and name preferences in registration forms, which is really helpful. We do have a gender identity on our Epic. So for those of you at HHS, that's a great thing to bring up with the people who are building your Epic. And again, it really behooves us to know how to do a proper sexual history. If you don't know how to do sexual history, you feel uncomfortable, you should learn to be comfortable with that. And again, gender neutral spaces, including hospital rooms and restrooms. So those are just things that we can do that don't actually really, when you actually look at all this, essentially costs no money. This is not a huge cost to the hospital. It actually costs virtually $0 to do this. The only cost I can really see in there. Oh, Kevin, did you have a question or? Oh, you just flash back on. So anyways, in the last couple of minutes, I thought I would just talk a little bit about complications of hormone therapy. So for those of you who work in the emergency department, the most common, probably the most likely significant complication we'll see is blood clotting related to estrogen use. And I go through an informed consent. Every visit I ask my clients, do you have any chest pain, shortness of breath, leg swelling, unusual headaches in the last 3 months? So I ask them all, and I tell them all, you can't call me, you have to go to your emergency department if that's the issue. And you might even see me there. But the point being that, so DVT, PE, venous sinus thrombosis, I've seen all of these in my practice, not at a great level. We have about almost 700-800 transgender females in our practice, and I've had about 3 or 4 venous thromboembolic events over the last 10 years. The lifetime risk is quoted at about 1%. And again, usually with testosterone, the biggest concern is secondary polycythemia, meaning that testosterone will drive red blood cell production. You'll definitely see that. And, if they're not being followed along properly, then they could present with stroke-like symptoms or cardiac symptoms. Actually, it's interesting. I talked to 2 patients in the last 2 days who were referred to me for surgical paperwork, because apparently people can't do that, but it's okay. We're happy to do it because we know how to do it. But and they'd both been on testosterone from their primary care providers for over a year and had never had any follow-up blood work, which is interesting because we manage secondary polycythemia all the time on our trans male patients. We're always reducing doses, changing doses because of that issue. The other one that you might see in a transgender male is transaminitis. However, by far and away, still the most common present cause of transaminitis, even in a transgender male on testosterone, is fatty liver, by far. I think I've had maybe once or twice I've seen a true transaminitis caused by testosterone, as compared to almost exclusively is always fatty liver when I do an ultrasound. Post-op complications, generally you'll find that most of them are related to urethral stenosis or urethral issues. So urology, if you don't have urology at your hospital, obviously at St. Joe's we're fortunate that we do, but again, most urologists don't know a lot about post-op care. And again, when most of the surgery is done in Montreal, we can't just turn around and call Montreal. So we do involve our urology colleagues on occasion, and they're often about as skilled as we are at that issue. So it does sort of. The other thing that we see a lot post vaginoplasty is granulation tissue and sometimes infection. Infection, for the most part, you can treat either as BV or you can treat with Keflex if you think it's more likely a staph infection. Granulation tissue, there's a lot. You can actually take a silver nitrate stick and just burn that granulation tissue if you're so inclined, or you can leave it for someone like me to do. We're happy to do it in the office. Yeah, we just do it in the office. We don't do anything special for it. And again, with transgender males, when they have phalloplasty, which is generally done in 3 stages, it's quite, as I said, it's quite a complex procedure. Almost universally, they have some type of urethral complication, most likely stenosis. With chest surgery, so top surgery, which is mastectomy, sometimes you see nipple loss and infection, and those can occur. So that's apparently the code Amber told me to put in. So I don't know. Do I just leave it there, Kevin? What do I do with that? Is that like calling? I watched Disney Plus Independence Day, so I feel like I'm calling aliens if I leave that up. So I won't cause an alien invasion if I leave that up, Kevin. I'm okay.
You might, but we'll leave it up there anyways.
Okay. Are there any questions that people would like to ask?
Is that your Bitcoin wallet?
What's that, Mike?
Is that your Bitcoin wallet?
Yeah,
It's on the screen.
that's my Bitcoin, Mike. Yeah. Good luck. I'm the worst investor in the world. Really, don't follow me. We're good. No questions. Perfect.
Carys, I have a question for you.
Yes. Yes, Kevin.
I do, thanks for the talk. For transgender health, do you find that because you're an expert in that, do you also provide, I don't want to be as sensitive possible, but psychological help for a lot of these patients, because I find that they probably do go through, unfortunately, a lot of stereotyping and trends, misogyny, and those terms that you. So how do you provide those treatments? Because I find a lot of them may come to the emerge, and that might be a thing that pops up, and I want to provide as much help mentally as well. So what are some pearls you may have for those patients that come to the emerge?
Kevin, I think just really the simple things that we talked about, like gender affirming care, right? I mean, that's the key. Most of my trans clients, I mean, I find that, I mean, yes, obviously I deal with a lot of mental health issues. I don't personally provide therapy because I quite frankly don't know how to provide therapy, but I talk to them, and a lot of it's really just about those things we talked about, being sensitive, using, preferred names, preferred pronouns, doing things like just that simple thing of calling to you guys and let them know in diagnostic imaging, because a lot of people are terrified of I was terrified of diagnostic imaging for years, right? Because there's nothing that can out you better than an ultrasound and an abdominal ultrasound, right? Like nothing can out you better, or a CT, right? And so it's really worthwhile letting the radiologist or the techs know, because although it seems like a little thing, again, when I talk to my patients, it's often GI where they have the experience that really hurts them, that really bothers them the most. Again, just talking to when we make a consult, talking to our colleagues and saying, look, this is a transgender patient. This is the issue you're being consulted for, but please, these are their preferred name and pronouns. Just doing things like that really alters the experience for a transgender patient when they come to the emergency department. It makes a huge difference. As I said, it's not really the medical care, right? I've never really found the medical care to be substandard for a transgender patient. I found it all when I get my patients, notes back from the emergency department. I think the care is always quite appropriate, to be honest with you. And they find things sometimes that I miss. So, again, it really comes down to that issue of being empathetic, being sensitive, and using those clues that, again, cost nothing, that make a huge difference to transgender people in their emergency experience.
Awesome, thank you. I'm just going to make a few comments from the chat box there, Carys. So sounds like the PrEP medication is Truvada. I think that was the.
Oh, that's Truvada. Thank you. Yes. I forgot to come back to that. It's Truvada, correct.
And sounds like Sunil is revising a manuscript on scoping review of LGBTQ ED care issues with Blair and many others, which is great.
Good work.
In terms of that,
in
that's amazing. And then Aleem is saying that for EPIC, for HHS, gender options are already on the build list, which is great as well.
That's amazing to hear.
Jada Fitzpatrick says that there is also an alternative to PrEP, which just gained Canadian approval, called Descovy, for folks on Truvada who are intolerant to or have renal side effects.
Okay. Yeah, we do PrEP at our clinic. We have a PrEP clinic at Quest, and I'm the medical director, so I should probably know that, Jada. Thanks.
And then I think Sarah has a question on Truvada. Do you want to ask Sarah?
Yeah.
Oh, yeah. Yeah, thanks. Hi, Carys. Thanks for doing this. It was really helpful and interesting. I just had a question for offering PrEP in the emergency department. Like, what would you qualify as like high risk enough behavior that you would offer it? I think like I just had a concern about like offering it blindly to like everybody who like identifies as like gay or LGBTQ, and then kind of making an assumption of that all of them would be participating in like high risk sexual behaviors, which isn't the case. So then I just was wondering, like in the sexual history, like what would be some flags that you would think like, oh, like maybe this would be someone who would benefit from it?
I think you just brought up all the key points there. And I think the issue is, again, it's not whether you're LGBTQ, it's around behavior, right? And I think that's really the key. So, I mean, we should remember that about up to 10% of men who identify as heterosexual engage in high-risk sexual behavior. So high-risk sexual behavior is anal intercourse for the most part, IV drug use, or people who are involved in sex work. So those are people who would be considered in the high-risk categories. And, you know, again, if they're monogamous and have a single partner, then yeah, you certainly don't need to necessarily, well, you don't need to provide Truvada in that situation. So again, I think Sarah, you brought up a really good point there. It's about behavior. It's not about identity. So again, you know, that's why I say sexual history is important, because we should be actually, it doesn't matter if you're part of the LGBTQ community or you identify as heteronormative cisgender, that we should be doing, you know, we should be asking about doing a sexual history. I mean, if you have an 82-year-old who has a Carys fracture, you know, maybe you can skip the sexual history part. But I just think about sometimes it's an opportunity in a younger person, particularly if somebody presents with, you know, history that might be consistent with an STI. Again, that's certainly an opportunity for you as a provider to tease out the high risk people. And, you know, I mean, at St. Joe's, we see IV drug users every day. Like every day we see IV drug users. So again, it's an opportunity to at least tease them out and refer them to the RAM clinic. If you work in Niagara St. Catharines, we do at Quest, we do accept patients to put them on Truvada. We have a clinic there. So if you're in Niagara St. Catharines, we can also do that at Quest for you. And the other place that does it in Hamilton is the SIS clinic, which Dr. Kevin Woodward runs as well. Does that answer? Hopefully?
Yeah, awesome. Thanks.
I'm just mindful of time. There's one more question that may be very practical for you, Carys, and then if anyone has any questions, please feel free, if it's okay with Carys, to send emails. Catherine Tong is just asking if you take e-consult for people who can't reach the clinic.
One of the beauties of coronavirus, I guess, if there's anything good about coronavirus, is our ability to change the way that we practice. So I did used to do OTN with, you know, really northern communities, so like fly-in communities, because they have no opportunity to access that care. But I didn't do it with people who could access a clinic, but people would come from as far away as Sudbury, Kapuskasing, Kirkland Lake, downtown Toronto, Ottawa to see me. So what I would say is, I think, yeah, I mean, with the way that we're doing business now, I'm happy to do e-consults. Yep, 100%.
Awesome. Thank you so much, Carys. This is an amazing talk, as always. There was just one note. RJ had obviously shared that Carys is in an Amazon Prime movie, which is amazing. So check that out if you have time, as well as if you... Pardon?
It's not Independence Day or Braveheart, by the way, in case you were wondering.
Right, and you can also listen to her TED Talk as well, very easy. But thanks for your talk, and like I said, check us out on YouTube. Otherwise, have a great day, everyone.
Hi guys, thank you.